100 years old.
Be able to interact with
Things I always worry about is being dependent on somebody. And
Healthy.
Where I would continue to be engaged and productive.
To become an old, young, active person.
Over the course of human history, most people died before the age of 10, with an exceptional few living into their 60s and 70s. Around 150 years ago, a remarkable shift occurred, and the average length of life began to increase. Every decade, about 2 years were added to average life expectancy. This trend continued in Western Europe and North America until, by the close of the 20th century, life expectancy had doubled for most people in the developed world.
And those additional 30 years of life that we added in the 20th century, we call the first longevity revolution. It was primarily improvements in public health, like clean water, sanitation, indoor living and working environments, controlled air temperature. These are all the things that created very harsh conditions for people in the early part of the 20th century. We wanted to live longer. We didn't want our children to die. We succeeded in doing this. And we got exactly what we wished for.
Today, the numbers of people living to old age and to super old age are rising around the globe. To live a long life is a monumental achievement, and longer lifespans are precious gifts for everyone. But there is another side to this story.
50% of the children born now will live naturally to over 100 years. But if we don't increase health span, what it means is that individuals are going to still succumb to cancer, heart disease, diabetes, and neurodegenerative disease at some point between their 40s and their 70s.
Has anyone heard of health span? It's the amount of time you're estimated to stay healthy into your older age. That means you're going to avoid cardiac disease. Right now, health span lasts till about 63, lifespan's about 79. This was 10 years ago. It's not really changed much. It might have even gone down a little with the pandemic and such. So, aging begins in childhood. Rate of aging is what this whole concept is about. There's a book called Outlive by an author, Peter Attia. Read it. He discovered this. I found this independent, and then I found him, and it's just like, he really explains it very well. If I do a good job today, you're going to walk away being curious about that book. So the goal is to, he said, kids born, and this was 5 or 6 years ago when that film was made, that they're going to live to be 100. And how do we know, how come? And it isn't, we've discovered something at several institutions, children's hospitals. This is happening all over the world now. And it has to do with the child's ability to have impulse control. Has anyone heard of the marshmallow test? Okay, that is an oversimplified version of some of what I'm going to talk about today. The Dunedin study, Dunedin study, Google it, please. It's very important and key to the hypothesis and argument I'm going to be developing. So we want to not only increase lifespan expectancy at birth, but how long will these children avoid chronic disease? Things like criminal behavior, addictive behavior, even the way their faces age, the way they look, can be impacted by the protocol I'm going to share with you today. So here's me, my affiliations. One of my heroes, Sally Fallon, please sign my book. I was looking for you yesterday and today, and you're going to follow me. I'm going to be talking about heroes, and I'm going to be talking about mythology and how does that relate to anything that I'm talking about. And hopefully, if I do a good job, you will understand the connection. Michael Gelb is here today. There's some people that were in New Orleans. This is where I introduced this concept of mythology and how it relates. I am going to define what early childhood is according to the World Health Organization and the American Academy of Pediatric Dentistry. Early childhood means under 72 months old, period, under 6 years old. Okay, so that is really, when you hear that term, it just doesn't mean a young kid or whatever. So birth to 72 months old, that's early childhood caries. That's in the International Classification of Diseases, the Academy of Pediatric Dentistry. If a child has one cavity before the age of 72 months old, they have a diagnosis definitive of early childhood caries. And it was done so medical insurance would cover the hospital costs if we got to take these kids to the OR. If they have more than one cavity, guess what it's called? Severe. I'm going to make a case that there should be also something for malocclusion. Any malocclusion, skeletal malocclusion phenotype that's detected before the age of 72 months old should be diagnosable as a health comorbidity, not just cosmetics. Okay, so I showed this, I talk a lot about anthropology. I recently gave a talk in Philadelphia. That's Taylor Swift's future brother-in-law. So I tried to find somebody, that might actually, be from Las Vegas that I could make fun of. But anyway, so I just threw that slide in here. So here's what our goals are going to be today. And, suboptimal dentofacial skeletal malocclusion in early childhood. It will not ever self-correct if it's truly skeletal deficiency. It's usually hypoplasia in the transverse dimension without a crossbite. If you upright the lingual verted lower molars, you're always going to get a crossbite. So the reason we don't fix it until there's a crossbite. There is a crossbite being hidden because the lower posterior segments are tilted in, they're lingual verted. So, and can you expand the mandible? And then, you can't expand the mandible. You're right. Orthodontist who criticizes me for being unethical for treating little kids. Of course you can't expand the mandible. You can't suturally expand the mandible because there's no suture. Good job, you remembered that from your orthodontic education. Okay, but you can develop the mandible. You can upright the posterior alveolus, and then you can suturally expand the upper jaw. I usually do it in reverse order. I always treat the maxilla first. Ben Moralia, one of my partners in crime for the Airway Health Solutions, he says, the maxilla is the criminal, the mandible is the victim. I always advocate, get that maxilla developed. Then, and the lower will come with it for a while, then it won't, and then you add a lower one, especially if the lower sixes are about to come in. Okay, and it's really interesting. Some people have heard me talk and they watch online and they see the protocol and they start doing it. And then other times, I've had actually somebody, here at this meeting, one of the doctors that I work with says you didn't teach them enough that they feel comfortable doing that. Well, that is my fault. I didn't manage their expectations. I don't expect anybody here to be able to go back on Monday and start doing this. I want you to start assessing on Monday, validated risk assessment, but you don't have to treat. You need to risk assess until you get comfortable. Treat your dental assistants' kids. Treat your relatives' kids. And you can make mistakes on it. But you know what? It ain't rocket science. And I was out to dinner last night with a dentist from Colorado, from near Fort Collins. And I kept saying, it's not rocket science, it's not rocket science. And then at the end of the night, he's like, yeah, I'm doing this and all that. And we're asking each other, what do your parents do and all that? My dad's a rocket scientist. So he's an astrophysicist. He worked for NASA. It is like, I'm sorry, I didn't mean to insult you, but it really isn't, you guys, this is so straightforward. But you do need training and you have to develop a comfort level. Orthodontics is usually done, see them by 7, but treat them at 9, 10, or 11. Let the problem get worse. I say that's a word that starts with bull, has an S in the middle, and it's not bullseye, okay? So that, and I'm going to develop that argument. It's a hypothesis that I have. I'm not saying it's 100% true, evidence-based, I'm going to talk about that, but people should premise things, with, look, it's a hypothesis. I can support it. I've got support for it. So masticatory hypothesis is really why there was no need for an orthodontist. Malocclusion does not enter the human condition till about 400 years ago, and really not really all that fast. It was mainly rich people. It wasn't proletariat. It was royalty. And now we have this. Okay, has anyone heard of Joseph Campbell? Okay, he's one of my heroes. And what is a hero? Well, he talks about mythology, and he said that there's, we shouldn't be pejorative about it, is there's truth there, truth based upon the people who came up with the hypotheses, all right? But if they don't get updated, they become laughable, okay? myths need to be updated, and then they become hypotheses, scientifically defensible hypotheses. And I heard him, I met him in the 80s, and when I heard him talk, it really put me on a path to start being curious about things that I'm now curious about. Mythological heroes, here's one of mine, Weston Price. Just like Darwin, he got stuff wrong, but he got a lot right. One of the things that he didn't develop enough, I think, and I wanted to ask Sally about this because she would know, is that and he, like everybody else, talk about nutrition as being the science of nutrients. It's biochemistry, trace elements, phytochemicals, macronutrients, micronutrients, vitamins, all that. I have a master's degree in nutrition and dietetics, and I didn't learn anything about biological processing of food. How do we acquire it? Chewing, mastication. I think a lot of the effects that Weston Price saw of cultures that weren't Western exposed, they had beautiful teeth, well-aligned teeth, no decay. And, it might have been vitamin K. I actually had a very astute dentist bring her children to me, massive crowding at, 3 or 4 years old. And she goes, I just read this book by Stephen Lin, and it might be vitamin K. And it's like, oh, it's not vitamin K. But that probably had maybe something to do with it. But no, biological processing, food processing, the Masticatory Hypothesis, okay? So he was very good friends with, who's the director of Star Wars? George Lucas, okay? Joseph Campbell was friends with him and helped, they didn't know each other, they became friends, but George Lucas came up with Obi-Wan Kenobi based upon what he had read in Joseph Campbell. And they taught method, they taught this mythology, but it taught lessons, or like parables, okay? This is Peter Vig. I grew up in dentistry in my pediatric residency at Iowa. This is an academic legend in orthodontics, okay? He was head of every society. He's got more degrees after his name than a thermometer, as my dad used to say. And you know what? He right now, John Mew and Mike Mew, they're under scrutiny by the British Dental Association. And this is one of their main critics. And he says you need good science. Well, I'm going to bring him up later when I get to the section on orthodontic mythology, okay? Because he says something that I call it cognitive dissonance. He holds two opposing views in his head and can still talk as if they're not opposing each other. So you'll all see it. This group especially will see it. So anyway, that is how Edward Angle, another hero, okay? And he came up with his classification of malocclusion based upon a 300-year-old prehistoric skull, okay? And that's where he came up with this idea we shouldn't pull teeth. Okay, nature didn't give us the potential for 32 teeth because we have extra ones. The jaw's not big enough. And he advocated expansion and things like that. Well, Peter Vig kind of ridicules this a little bit, and you'll see it in a clip that I'm going to show later. So, one word about evidence-based medicine. Didn't happen until after World War II, after the Nazis were on trial at Nuremberg for what they did to humans. Okay, awful things. I don't even like to think about it, but that's where IRB comes from. Did anyone know that? I didn't know it till the head of sleep medicine, Lurie, told me about it. Is that we got to get through IRB, and do you know the history of IRB? Nuremberg trials, ethics, okay? Well, look at all the discoveries that were made before evidence-based medicine. Powerful, controlled observational trials. Vitamin C for scurvy, right? Cholera being a waterborne, not an airborne disease. Read the Ghost Map, great book about John Snow, the MD who figured it out. Okay, but it wasn't a randomized, and let's withhold it from one. It was automatically withheld from other places that he didn't study. So I'm really big on reading old pre-World War II literature. What I'm going to talk about, the protocol, in terms of expanding, spreading the deciduous arch, okay, for not the purposes of creating irregularities of teeth. If they're crowded baby teeth or no space, or, that'll improve that, but that's not why you do it. For a nasal respiratory advantage, okay? And inattention, they didn't call it ADD. This is all understood in the late 19th century. I'm going to talk to you about one of my heroes, Edward Augustus Bogue, MD, DDS. He expanded his first deciduous arch 7 years after the end of the Civil War. Okay, so this is not brand new. We're rediscovering this as being a validated hypothesis. Okay, 30 months of age. This is JAMA, 1922. Dr. Cohn, MD. 30 months of age is the ideal time to begin the fix. Begin the fix before 6. That's just a little poem we have. But this is where I got it. Okay, and I got a stack of pre-World War II literature that absolutely discusses how this was being done. Okay, and look what else. Okay, like at 4 years of age, if a kid isn't 28 millimeters between his upper second molars and the lingual, guess what? They're already growth deficient. And hypothesis, okay, but supportable. And Bogue worked in Paris, London, New York, Boston, and Chicago, seeing thousands of kids. He had a collection of study models at the Forsyth Dental Institute at Harvard that it's probably not there anymore. I tried to petition to get in there to see if they're still there. But this is very reliable. Look at that, 2.5 to 6 years old. That's what's the magic about 2.5, 2.5 years old, 30 months of age? You got 20 baby teeth. You can put an expander in there. If you see a transverse deficient child, there's also almost always some sagittal deficit as well, whether it's an obvious retrognathic class 2, a maxilla that maybe isn't an anterior crossbite and obvious class 3, but if you've got a mandible that's a mile back, your maxilla can be 3/4 of a mile back and you still have an excess overjet. So what does that tell you? Unless you're from planet Krypton, you need an x-ray. And I was asked to speak at the American Dental Association last year, and there's another course coming up. I'm on a task force at the ADA, and it was radiation safety. And it is, if you have a cone beam that, 4.5 seconds, 7 microsieverts, or a standard Panorex, 7 microsieverts. That's like 2 days of outdoor background radiation, okay? It's not unsafe. I'm not cavalier about ionizing radiation at all, but they're saying we don't even need to put lead aprons on anymore. We still do it because parents want it, and that's fine. But you really, and vertical growth, you call it adenoid face, long face syndrome, kids who are, mouth breathers. It's very difficult to detect without an x-ray in a kid under 6 years old. They got baby fat, and you got kids with dental deep bites who've got skeletal open bites that'll make you won't believe what you see. And I think I'm going to show one of those here. So this is a worksheet that I want to give to everybody. I will give it to Becky or somebody that can distribute it, or Rich, that everybody can. It's a worksheet you can use in your office. There's the reference for it. The reference is from over 100 years ago, but whatever. It's still very reliable in picking this up. That looks like a Lefort. Okay, that's Dr. Bogue. What he did with models, this is what the expansion does. And when you expand a kid transverse, guess what else comes forward? The maxillary, premaxillary area. There's a suture there, the incisive suture. It's where the Lefort cut is made. Okay, and that is still very patent in a child. It's patent in young adults and some of the pre-industrial skulls that Mariana Evans, dual-boarded periodontist, orthodontist at the University of Pennsylvania. We are going to be mentoring 5 different Philadelphia ortho and pedo programs for research. We were just invited there to do that. Look at the title of these papers and look how old they are. All right? The Relief of Nasal Obstruction by Orthodontia, a plea for early recognition and correction of faulty maxillary development. You can read those, and everyone's going to get these slides, please. And share them and use them. I'm not real possessive of my slides. This has got to get out there. So there's Bogue, and this is, how he explains his hypothesis and what he did on thousands of kids and treated. So why are we here? Would anyone argue that 2.5-year-old has a skeletal malocclusion? Does anybody think that will self-correct? Okay, if you do, hopefully by the end of this, you won't. Okay, and how about the girl on the right? Class 3. Both parents were told there could be a syndrome. They're probably going to need surgery, whatever. And quite frankly, I had to say that too. That's unethical to say that I could rescue this and your child will never need surgery when it's that bad. But I say you have cause for optimism because I've been doing this for 33 years and I've got some great results to show you. They're not published. Hopefully I will be publishing some of this stuff. This was in the journal Science. Not too bad, you guys. Science, it's the oldest scientific journal in the world. And they followed a task force that we had we went to Duke University. And for 3 days, anthropologists and dentists were discussing how come anthropologists don't understand that their fieldwork, their theory can be applied clinically. How come dentists and physicians aren't learning about anthropology and evolutionary biology in dental school? Does anyone know where you taught this? Tooth decay does not enter the human condition until about, well, I don't want to give it away because I'm going to be showing a slide about it. But it really has not been with us that long. It's a brand new disease. Malocclusion is even younger, okay? How in our genome, how quickly can our genome change? It takes thousands of generations for a macrogenomic change. Microgenomic change can happen. Lactose intolerance, that's the wild state. That's normal. Everybody was lactose intolerant. When you were done weaning by 4 years old, that enzyme shut off because we didn't kill an animal for their milk, okay? We chased them and hunted them down for their meat and their marrow. You guys were eating marrow last night at dinner. I was like impressed. So this is where I'm doing, working with Mariana Evans, looking at ancient, it's the Morton collection.
Janet Monge, I'm keeper and acting curator of skeletal collections at the University of Pennsylvania Museum of Archaeology and Anthropology. What's illustrated on the side is actually the part of the Samuel Morton collection, which actually was collected in the middle part of the 19th century by a Philadelphia physician who was very interested in human variation from a lot of different perspectives. One of the major contributions that he made was actually not just amassing all of these skulls, which in his lifetime was about 1,200 or so, but was continued after his death by his student and colleague,
So anyway, they're all ages, 1,200 of them. I study fetal skulls. I study, before age 12, and those are called pre-adults, subadults. And if they have wisdom teeth, usually by 13 or 14, those are the adults, and Mariana does most of those. And we took them to her office. We did cone beams on them. We've got these measurements. And it isn't that, there's ratios. And the hypothesis that I'm really advocating is if a child, we don't see any malocclusion. There's a few maybe dental, rotations and things like that, but there's no appreciable skeletal malocclusion in any of these. In fact, they have erupted third molars and retromolar space behind it. Okay, and the theory is we haven't needed third molars for the purpose of survival relative to eating, right? We could live without them, and they're often there's agenesis of them, but we need room for them. We don't need the wisdom tooth. That's why they haven't gone away according to this hypothesis, because we need room for them. Because that means there's room for our tongue, and that means our jaws are forward, and that means our airways are not collapsed, and we can sleep and breathe. Hypothesis, not a fact, it's a hypothesis, but we have evidence to support it. So this is something that we've come up with, another hypothesis. That guy on the right, okay, he was 35 years old and he died 14,000 years ago. Now, can you tell me what he looked like when he was 20? According to our hypothesis, yes, precisely. Can you tell me what he looked like when he was 10? 5? 5, we'll stop there, 5. I know what he looked like at 5 because he lived to be 35. The hypothesis is you wouldn't live long enough to develop malocclusion if you had antecedents to myofunctional disorders. Are there myofunctional therapists in this group anywhere? Yeah, cool. You know what? Hats off. Can't live without. I thought it was voodoo when I first heard about it 15, 12 years ago. I can't live without it. In fact, I'm reluctant to treat a kid unless they will at least have a myo-evaluation because it's myofunctional disorders that lead to all malocclusion. Another hypothesis, but supportable. Okay? So how about this kid on your left? Can you tell me what he looked like? He's 12 or 13 there. Okay. Can you tell me what he looked like at 9 or 10? That's what that kid looked like. Okay, that guy looked like that. Okay. But that's that guy. He moved to Chicago from Seattle looking like that. I treated him non-extraction. That never occurs in the pre-industrial fossil record, skeletal and fossil record, because nobody would live long enough if they had antecedents to that. So that's just, something that, and we measured, there's the Bogue index right there. You measure it at the gingival margin. It also, I put the canines but now we measure canine custip to custip, and it's almost identical. If you can't get back there, if the kid's a gagger or whatever, a cotton roll is what, 36 or what, or 20, what is a cotton roll? Because that you can use that, but I buy these Home Depot things. You can cold sterilize them, they're little calipers. But we measure these on all, but you can measure them on an iTero scan, you can measure it on a cone beam, on a study cast. So, and this is our research. We're doing research with Mayo Munchie. And I wish I had time to talk about that, but we're actually palatal depth. People, he's got a deep, narrow palate, but nobody's quantified it. What is a deep, narrow palate? It's very subjective. It's a reliable proxy indicator of transverse deficiency in the absence of a crossbite. So always, those kids are transverse, and it may be an optical illusion. The palate isn't necessarily going up into the nasal cavity. The transverse walls are in, and it looks deep. And when you widen it, it looks, less deep. I ran this theory by the two most prominent dental anthropologists in the world, and they agreed with me that absolutely, you could predict. Now, Dr. Coracini, who came out of retirement for me and Mariana to mentor our activities at the Penn Museum, he said, Kevin, no, you can't say that. Why not? I mean, humans have been around for how long, and can't I just say that had to? No, you can only go back 20,000 years because we don't have enough babies. Okay, I'll take that. You can go back 20,000 years. But if there were more samples, we could say from when humans started becoming anatomically, human, from transmutation of other species, this is probably what happened. Look at this, the head of Harvard ortho department. And the face evolved, not the jaws, not the teeth, not the air. The face evolved. The front of the airway is the face. The back of the face is the airway. And I call it the craniofacial respiratory complex. I'm going to develop that. But mastication, chewing and breathing, that's how the face evolved. Most of you have heard of Moss's functional matrix theory, but most people don't know what a functional matrix is. They can just spit it off like that, and it wasn't until Tim Bromwich brought it up. The functional matrix of the jaw, what makes the jaw big? Chewing. Chewing what? Food. That's the functional matrix of the masticatory complex. Then the respiratory complex, what is the functional matrix of the respiratory complex? Anybody? O2, oxygen, okay? Air, ambient air. That's what expands it. That's what develops it and grows it. If you're not a habitual nose breather, as early in life as possible, you're going to be compromised, okay? And in malocclusion, they almost always go together. If you see a kid with lots of malocclusion traits, my first question is, well, do they snore, right? That's a validated. But no, did your child have eczema? Does anyone know about that connection? IgE. Almost always mouth breathers. Mouth breathers always have malocclusion. So ask that question. It's validated. I've written a chapter on it in a medical textbook. I have 4 book chapters I will share liberally. If you just, sorry, Rich, I'm going to have people email you or Becky. But this is important. So there's us in Mariana's office. I'm also, we're taking a break at Arkansas, but I was mentoring PhD dental anthropology research. And my candidate is taking a hiatus from it, so I'm not really in since the pandemic. But we were going to publish on the Bogue index, okay? And that's the measurement, and we're correlating it to what we would get on cone beams. And what is it in pre-industrial skulls? This is amazing. The norms that were created in the 50s by mainly Steiner was based on his own kid. very subjective, and Downs did one too, but it just, there's not longitudinal samples. Sassooni and Bolton from Case Western University, they studied perfectly growing, what they thought were growing optimally. And it was very biased, and they had the first lateral ceph machine, the cephalostat. And if they take an 18-month-old, okay, this kid looks like there's lots of space, he'll probably never need braces. But as things progressed and maybe things happened epigenetically or environmentally, they got thrown out of the study. At the end, they chose 16 kids, 18 kids, boys and girls, 36 altogether. Paul Newman was in that cohort, right? Grew up in the Cleveland area. You know what his profile's like. And they said these are the norms that everybody should follow. They look just like what we're getting in the museum. Okay, so that is the best cephalometric norm to use, and that's what I use on everybody. So that's the Bogue Index. No time to really go into it now, but it is a very reliable metric for talking about transverse deficiency. So again, one of my heroes, he didn't really, somebody please, I combed all through this again when I was flying here, and I didn't find really too much about mastication as being the reason or lack thereof of good and bad bites, of well-aligned teeth and jaws. So, but he did a lot. He did so much and wasn't taught. I didn't learn about him in dental school. How come? Why is this not being taught in dental school? So anyway, I'm not going to go into all this. There's a lot of writing there, but he just found that it was Western diet, and he thought it was macronutrients and white flour and sugar, and he was right, but he didn't add that chewing component, I think. And the sugar thing, he absolutely understood fermentable carbohydrates and separating fiber from carbohydrate. That's what makes sugar bad. It really, if it stays with its intrinsic fiber, it really is not a bad thing, like in fruit, things like that. And fiber is where all the nutrients are. Who knew that, right? That's where nutrients, just almost all the nutrition is. So they remove it, and then they sprinkle some of it in and call it enriched. What do I call that? Starts with bull, has an S in the middle. It's not bullseye, okay? So the craniofacial respiratory complex is something, a term that we came up with in our research. And why has it changed? Okay, and that's something that Weston Price talked about. Again, you'll have this slide, but use it. Never say craniofacial again. It's like saying the CDC stands for Center for Disease Control. No, it doesn't. Center for Disease Control and Prevention, but everyone leaves that off. Craniofacial respiratory. And we have it in 5 textbooks now. So, one thing, a nutrient, does anyone consider oxygen a nutrient? It's there's macronutrients, protein, carbohydrate, and fat, right? They all can be used as energy substrates, right? I say oxygen is a respiratory substrate. It's a nutrient. And Robert Lustig, some of you know who he is. He and I talk about this. We get invited to conferences to discuss oxygen utilization. He gets it, from the physiological standpoint, and I talk about this whole relationship to nutrition. Okay, so here's your first quiz. Who wants to take a stab? Come on. Okay, so that's how long our speed that we can go back based upon mainly genetics. Now we know this with the human genome, is that we were anatomically modern human. Our genome has not really changed appreciably in that amount of time. It's still the same genome. We looked a little different, but you may, again, I make fun of whatever suburb I'm at when I lecture in Chicago, but if you put a 300,000-year-old anatomically modern human in modern clothes and put him on a Chicago train or bus, you might just think he's from, and then I make up the name of a suburb. But there is difference, but not really much. It's not a changed genome. So, and I always put the published reference flashcards from the Museum of Man in Paris for 5-year-olds. They're teaching this in Europe. Little kids know how old our species is. This is not in our school system. It's not in medical or dental education, that's for sure. You guys most of you know this stuff, but I love preaching to the choir. When I found out, how many people I've talked to that already understand all this stuff, I was just like, because I just didn't know. I talked 5 years ago in Boston. I think Rich invited me, but I forgot really what you guys were all about. Okay, so a few definitions. Ontogeny, that's what happens in a single generation. Okay, I got almost 50 minutes left, okay? They tell me I could have my full 75 minutes, so I'm going to do that. That's what happens. We used to call it cradle to grave, birth to death. And it's really conception to death. And then phylogeny, okay? So there you go. And delightfully human. Is she here? I always try to, put somebody in there that I know. And I don't even know if I've met Sally. I've talked to her online before, but anyway, I hope that's not offensive. So this is what happened. Industry. And, with the industrial evolution, we get malocclusion. We really had no appreciable. Life got started 4 billion years ago, like a little over 500 million years after the Earth cooled off. It could support life. They were called archaea, all right? They were prokaryotes, like bacteria. And then everything alive has two things in common, all right? Nucleic acid, RNA or DNA, and the Krebs cycle. They can make their own energy. That's why viruses aren't considered alive. They got someone else's nucleic acid, and they can't make their own energy. They pirate. So this is something, craniofacial respiratory complex, another publication. This is in a European journal, but one of the first that we got in there. That picture is from that science article. I was actually there. Part of that thing we did at Duke University, we were charged with going out anywhere we were invited. Dental professionals were to speak in dental schools and anthropology departments. Anthropologists were to speak in dental schools and anthropology departments about this hypothesis that Peter Unger, his name is, at Arkansas. He's the one who came up with this idea and formed this group. And I was in the Yucatan Peninsula, and I lectured at a dental school and an anthropology department. And then I got to go out into these villages watching these women, use this really rough stone ground powder. This is what happened in the Industrial Revolution. Who entered the workforce for the first time? Breastfeeders and baby-led weaners. Okay, wieners. That didn't sound good. Sorry, I made that up. Sometimes being spontaneous backfires here. Okay. So, but it really was, women couldn't stay in the home and nurse on demand and baby-led wean up to 3 or 4 years, what humans had done, hunter-gatherers, for almost our entire existence. So that's when artificial feeding came in, and wet nursing, hired somebody from the village who was lactating that can do this, or to give artificial baby food. So phylogeny is over a long time. Ontogeny is a single generation. Phylogeny could mean, like what Weston Price talked about, is that, look at the parents on this island in Scotland. They all have beautiful, perfect teeth, but their kids are growing up on Western food, and they have crooked teeth. Well, that's phylogeny. That's between generations. But when it's one generation, the same person, and I'm going to be developing this in Houston in a few weeks at the Sleep Education Consortium, Gerald Simmons. I'm going to show a slide, and you can take pictures of it. I'm doing an entire talk on this. But here you go. This is really beautiful teeth between generations. But look at this. One generation that can happen. And Price was the first one to really make that popular.
The last major milestone in the 7 million years of hominin evolution is the emergence of modern humans, or Homo sapiens, people who for the first time fundamentally looked and behaved like us. While a date of around 200,000 years ago was frequently given for this dynamic, there is still substantial debate regarding the timing of something that is an ongoing process rather than a single point in geological time. Anatomically, it is widely recognized that facial size reduction, or gracilization, or feminization as it is sometimes called, as well as facial retraction, are key defining traits for our species.
So that's what they do, like Bruce Jenner, Caitlyn Jenner. You know, they call the surgery feminization, all right, or gracile form softening. But that's happened to us. It started with agriculture about 10 to 12,000 years ago, okay? But it was slow. The faces, they got a little narrower, they started coming back, they were getting a little longer, but the teeth also were getting smaller. They were instead, you don't see malocclusion happen until about 300-400 years ago with industry, because the teeth stayed the same size, didn't have time to evolve, co-evolve the same way, but the jaws got narrower, they got retractive, they got longer, okay? So we know that. I can say that with confidence. When I see a little kid come into my office, I can look that parent in the eye. This is not going to self-improve. However, there's things we can do. They call it artificial stimulation. Artificial relative to what nature used to do. They would build that jaw, starting in utero, chewing and swallowing amniotic fluid, and that's the hypothesis I'll be developing in Houston in a few weeks. But certainly at birth, with nursing, baby-led weaning, nasal breathing, being papoosed out into the fields when mom was a gatherer and the dad was a hunter, whatever. And if they're papoosed, they have to keep their heads up. That's myofunctional therapy. That's posture. That happened. Learning to talk. If a kid couldn't click, that was the first speech that we had. We learned how to do that because hunting at night, another hypothesis, animals couldn't recognize it. It was a click sound, and they could communicate, and they learned to talk with clicks. That built the jaw. That's a lot of pressure. So lots of things go into building that jaw, okay? Genetics, sets it up, but the environment, the stimulations that they got. So this was first proposed, the dietary thing, by Dan Lieberman at Harvard, but he really didn't talk about infant and early childhood feeding. And he was he didn't know it, but he mentored me, like Weston Price. He wasn't even alive, but I've been impacted. He's one of my heroes. This is the Masticatory Hypothesis. It's really big in anthropology. I have over an hour, or half hour, sorry. Don't worry, Sally. Okay. But this is something that really, it's the leading hypothesis for why these things happen. So, begin the fix. I don't say fix by 6, I say begin the fix. You start it, you lay the foundation. There's still lots of work to do. I draw the analogy to ophthalmology. Nearsightedness, myopia, really bad since the pandemic. Close-up work, kids indoors, not getting vitamin D to the retina, all these things. Myopia is rampant. The axial length, the eyeball gets longer. You can't reverse it. You can't cure it. You can slow it down. This stuff, you can prevent it from happening or you can reverse it. But the analogy is, well, if you give a 4-year-old glasses and he's still going to need other phases of glasses, where we get it all the time, well, just do the ortho when he's older. Don't use up the lifetime orthodontic benefit. That's the biggest criticism I get from ortho. He's using up the orthodontic benefit. There's nothing left for us. Well, no, I treat him all the way through, and I make it less complex. But I never tell a parent, when I start your 3-year-old, I'm going to take a break after I do a little heavy lifting, and we're just going to guide them at their cleanings, and then I'm going to start up again. And then when they're 13, I can do Invisalign on them instead of braces. But they're going to need all of that. Okay, I don't sell it as this is going to prevent everything. So, fear and anxiety. This is the biggest obstacle, according to my hypothesis, for why children, they're not taught in orthodontic programs to treat 4- and 5-year-olds. Well, what if they won't open their mouth? You think I give a rat's if they won't open their mouth? I'm a pediatric dentist. I had to learn behavior guidance, child development. Also, studying anthropology, I know all hunter-gatherers raise kids. There's no timeouts. They play. They let them make their own mistakes. They are hardwired to assimilate adult culture. They like to imitate, and they like to please the elders. I know that. Every time I see a kid, I knew it when I had to give shots and pull teeth, and I don't do any of that anymore. I have never enjoyed dentistry so much as the last 10 to 12 years because I don't do dentistry anymore. This is all I do. And I'm doing the stuff that the orthodontists, they don't want to do it. They'll criticize me, but they don't want to do it because they don't get behavior guidance training. So ortho fear and anxiety, that's a mom, You get mom on your side, you are home free. I always apologize to dads. Dad, sorry, we don't have what she has. And if that mom can see that this is in her child's best short and long-term health interest, you're home free. They're going to do it. And they can find these videos online. I can show them my results. I've got kids that are, in medical school now that I started treating, at 7. That was really aggressive. I call a 7-year-old a geriatric patient now, okay? I'm treating them younger than that. But I have longitudinal data, and it's published. There's not mine, but there's published literature all over the place that this does work. So look at, that's fear. Not the kid, it's the orthodontist. They're scared to death of kids, and it's not their fault. I not mean to be pejorative against orthodontists. It's against their curriculum. Now, I'm on a task force at the American Dental Association, and that is one of our hopes, is that this is going to influence the way behavior guidance is taught to not only orthodontists, but pre-doctoral students, dental students. Most kids, 80% of children who are pediatric dentistry patients, pedo patients, guess who treats them? Not me. Primary care, general dental practitioners. And they're woefully unprepared. And you guys know it, wherever you went to dental school. And that's a criticism that is published. And so the whole curriculum has to change. And one of the things that needs to change is pediatric behavior guidance. And when you become a parent, and most of you, like when you graduated from dental school or pedo or ortho, you weren't married, or you were married without kids, or you were married with young kids, and you just didn't. But once you become a parent, it's in you. It's already inside of you. And you'll remember how your parents raised you. And it is not rocket science, sorry, but it really isn't, especially if you're a parent. You know how to do this. Trust your instincts. But we really should have continuing education courses in this, and that's another thing we're proposing at the ADA. So it's the curriculum, okay? I won't spend too much time, but what else do we need to fix? Orthomythology, and I'm going to be doing a section on that coming up here, and I still have 28 minutes. It's funny, the guy who did AV at the last meeting I was at, I said, look at Thor throwing, lightning, and he goes, that's not Thor, that's Zeus. And it's like, you can learn, thank you for telling me that. And then I thought I better look this up, or people are going to think that's where I think lightning comes from. Lightning comes from air insulating positive and negative charges in a cloud. And when the charges build up, the air can't do it, and whatever charge is in the lead will connect with the opposite charge on the ground or to another cloud. That is lightning. So there you go. I had to learn it. But the myth is there, this is what the Greeks, this is what they thought. Okay, well, they need to update it. Otherwise, it's going to be laughed at. Deciduous dentition predicts orthodontic treatment needs later. Isn't that useful? You can help parents save up their money for braces. That's like an ophthalmologist telling a severely nearsighted 4-year-old, save up your money for glasses. Wait till he's almost blind, and then when he's driving a car, maybe the lenses will make it so he can pass his driving test. Ludicrous. Nobody would ever say that. But people who are influenced by the orthodontic protocol, I'm not picking on orthodontists, it sounds like I am, but I'm really not. It's the protocol. And I was a pediatric dentist. They didn't teach me. I went to the one most aggressive ortho, it was a pedo program, but very aggressive in orthodontics. We treated at 7 and 8. And we were criticized by the orthodontic department, using up the orthodontic benefit. You can do it later. Okay? This is what that should say, is that when we know, and this has been known for 100 years, most dental students can tell you it won't get better, but you can fix it later, maybe pull teeth. All right, wear braces to your junior prom like I did in the 60s. Tooth pulled, headgear. I'm not overweight, and I have apnea as if I weighed 400 pounds. Okay, so I have to have some jaw work done. But it will persist, right? And it will get more complex. I don't use the word worse, but that's what it is. And if it isn't already, it will become comorbid. I don't say risk factor. Comorbid with sleep and breathing, neurological, cardiac issues, blood pressure. Okay, these are all things. Why am I really so excited about this? Because little kids are getting hurt. And then this whole thing about self-control. If you don't optimize ability of a kid to do well on the marshmallow test, you're doing a disservice. And a lot of kids who don't have jaws and faces that are well developed in airways, they're going to have inattention issues. ADD, according to Steve Sheldon, starts with bull, has an S in the middle, all right, disease. It's called a psychiatric disorder, whatever. The symptoms overlap with sleep deprivation in kids. When you expand a kid and you do myofunctional therapy and you do, if there's lip tongue tie, I stay away from that controversy, but if you optimize a child's structure and then the function to habitually nose breathe before they turn 6 years old, you should pat yourself on the back. It's doing wonders. So Mariana Evans, periodontist, she calls it juicy bone. See those blocked out canines there? Another reason you should take Panorexes on before they're 6. Academy of Pediatric Dentistry says by eruption of the first tooth, take your first Panorex. Less than 7 microsieverts in a standard analog Panorex. That's the same of a full cone beam if it's an ICAT flex machine, okay? But look at now, I expanded, that's called in-bone crowding. If you do nothing else for that kid, even if you're not buying the respiratory aspect of it, and behavior and self-control and all that, you are creating an alveolus for that follicle to erupt into that has beautiful periodontal support, okay? They're going to be less susceptible, and she calls it erupting into changing in-bone crowding so that the teeth will erupt into juicy bone, okay? So lots of reasons to do this. I expand and I treat almost every kid as if they're a class 3 because, like I said, if the mandible's a mile back and the maxilla's 3/4 of a mile back, you need to get it a mile ahead so you can bring that mandible forward. And the mandible will start to respond with myofunctional therapy. It'll start to grow forward. If you get in early enough, you usually have to do more with repositioning functional appliances, but not ones that'll pull back on the maxilla. I had a little discussion yesterday with one of the vendors about that. Brilliant kid who's running that occlusal guide, Healthy Start, yeah, brilliant kid running there, and he just knows Dr. Bergeson's protocol, but he's going to send me research because I really want to explore it more. Okay, this is any pediatric dentist in the room? Not a one. Oh, shame on us. We have a publicity problem here. Okay, we need more. But there's a chat line, and a pathologist put that in the upper right. There's a problem with that erupted 6-year molar. There's already resorption going on in the dentin. All right, what is this? And I said, okay, yeah, this is what it is, like everyone else identified it. But with all due respect, doctor, did you notice that the canines are blocked out? And that's a 4-year-old. And here you again at 6 or 7, canines are still blocked out. And guess what it'll be when they're 12? It's the same thing. Reliably, that is a proxy for lack of tongue space, risk for sleep and respiratory problems, cardiac problems, neurological problems. Why would you not, and nobody commented on it. Like not even, you bum, that isn't why she put that up there. But nobody commented on it. I waited a couple days. I really wanted to get into not debate, dialectic, constructive dialogue. That's what I like. I don't like, I'm right and you're wrong. Debate is the worst form of discourse when these things come up. But nobody. So I wrote to her personally. She's at North Carolina, I think, or Duke. And I thought, I apologize. I didn't mean to hijack your, whatever. She wrote me the nicest note and then published it. I have changed the way I look at children now, thanks to what you put up there, on there. I never would have paid attention to that after you. And I sent her references of where it's going. So, if you see something, say something. But, that's the door through which that canine would have to erupt. It ain't going to happen. It might erupt ectopically. It might not at all. It might get impacted. It might start resorbing the lateral incisor roots, okay? Why would you leave that? You need a Panorex on kids before they're 6, okay? When people say, well, the airway, that's the domain of the ENT. Yeah, you're right. And mine. Anything above the clavicles is my domain as well. A shared domain. We have to get used to saying that. No, it doesn't belong exclusively to either one of us, okay? Little advertising here. June 1st is a Saturday. That whole session is myself, my periodontist, my ENT, my sleep medicine doctor, and my myofunctional therapist. We're doing the whole session. It's like, this is how we do it in Chicago. Collaboration. It took us years to build this team. And this is some of the things that we're going to talk about on Saturday. It's live. They moved it out of the ADA headquarters because they're anticipating it's going to be a full house out by O'Hare. It's at a really cool place, and you can get into the city, or you can go to Oak Park, where I'm from, and there's lots of stuff to do there, and it's real close to O'Hare. So don't worry. It's on they posted it yesterday on the ADA website. And it's a hell of a faculty that we're going to have. So, all right, so I'm not going to go over, I've got hundreds of cases like this, okay? But this is extreme. Look what that happened. Well, you know what? Another orthodontist will say, well, they're still growing. But they don't say that the jaw, she'll get taller, but that transverse won't change after 5 years old. There's nothing that's going to happen there. The sagittal problem will become more evident, but it's not going to go away. They don't say that. They say she's still growing. Bring her back till I'm not frightened of her. They won't tell you that either. So, but look at that. You should see her now. And it's just, she's growing beautifully. So Chicago Hearts, this is something you can get from Kelly Richardson. She used to work for the Dawson Academy, and she has developed this. She's written a book. Look up Kelly Richardson on children and airway and malocclusion. I should have her book up there, but you can order this, and the money goes 100% just to cover the publication cost. It's a chair set of all the symptoms, and you can show parents, what the crowding looks like, what the crossbite looks like. This is, tonsils and adenoids. This bump right here, okay, that's the adenoid, and that distance to the soft palate, there's a metric for that. It's called the Linder-Aronson metric. I teach this to ENT departments. I get invited to lecture in ENT departments about this. And you can do this on a lateral ceph. This is it. This is the Linder-Aronson metric. And it is something that, and I've taught the radiologists at beam readers, they read all of them. This is from Audrey Yoon's paper that shows when you just transverse expand 8-year-olds, that you will get shrinkage of the adenoids, or normalization is the term that the ENTs like. Well, also what you do is you increase the distance from the foramen magnum to the posterior nasal spine. This gets bigger, okay? And I showed that on their paper and told them they didn't mention it. That's the Linder-Aronson metric. And again, I have a tutorial on this. I teach with Ben Moralia on the Airway Health Solutions platform. Some of you have taken my course. But please, consider if you want to do this, and I'm not the only one. ASAP Pathway, Bill Hang, there's lots of people, and we all need to promote each other doing this. More kids need to be served. This is a kid a week before his 3rd birthday. He wasn't 3 yet, and that is less than a bite wing. That's called a DX, or a Scout film, all right? And that adenoid showed up, and that kid had loads of symptoms on the pediatric sleep questionnaire. Look at that. 5 months later. Now, I usually don't take x-rays, but the mom's like, what happened? You expanded him. Is that accounting for that? Can I do another one? I told her about the radiation, and, yeah, please. And look what we found. Complete shrinkage of the adenoids in 5 months. Who knew that? And now, maybe they got rid of the family dog and cat, and the kid was allergic, or he stopped drinking milk. It's a sample of one. But that's what pilot studies are made of. I have a hypothesis. I think, because I see it. When I update x-rays in 20 to 24 months, I always see this. I didn't know it happened that soon. And maybe it doesn't, but I'm much more curious about it. Okay, so here's some cases. This is what happens, all right? When you correct at that Bogue index, that molar width and premolar width, look at the sinuses, all right? This kid had hypoplastic sinuses, right? Look how big they are, and that's on the radiology report. You send that to the ENT. If you see large adenoids, it's incumbent upon you to send it to an ENT for an evaluation, not for surgery. I don't refer kids for surgery. I refer for an evaluation, and it's up to the parent and them if they want surgery. But often, this will help surgery. Like there's a lot of failures. Adenoids grow back. Most of these kids are transverse deficient. I fix malocclusion. I'm a dentist, okay? That's all I do. Often the breathing gets better, the adenoids shrink, but I can't promise that. Go to the ENT. Most of the ENTs I work with, they know our and they'll say, just wait till Boyd's done. You know, we'll see. So it took a long time for that to happen. But look at that posterior nasopharynx, okay? That gets huge. I had a discussion yesterday with somebody who said, well, no, it's the hypopharynx or the oropharynx that changes. Well, that too, but the nasopharynx can change if the maxilla is not getting a headgear effect and it's being brought forward if there's myofunctional therapy done. This is great. This is a Linder-Aronson metric. I see this all the time. Mariana Evans took a cone beam on herself, like 3 of them within 45, every 15 minutes, and the airway changed on every one of them. So that doesn't really tell you much because there's collapsibility that has to be brought into account. If that soft tissue airway is collapsed then it really eventually with myofunctional therapy and what is the functional matrix of the respiratory system? Air. If a kid is breathing air through the nose, that whole thing will develop. It expands. Just like chewing food, hard food, firm food, baby-led weaning, these things all change, okay? So here she is. These are the Bolton norms that I use from Case Western from the 50s and 60s. I have 15 more minutes. But look at that. Who wouldn't do that for a child? Is anyone going to say that's going to get better? Most people didn't. The parents were told, save up your money for surgery. You know, there isn't much you can do about that. And they found me. And this kid had major, major sleep problems. Everything went away. And I can't say that every kid I treat, all their symptoms go away. They stop getting worse, pretty much all of them. The elevator stops falling, but often it'll climb back up to the top floor. So this was her, right? And you can see she still has crowding. And you know, we're almost done with her Invisalign now, but you know, this is something, but all these, I use the pediatric sleep questionnaire. We're developing one at the ADA. I'm on the screening task force. And people can, if they want to be a beta tester in this, let me know. Because we're saving, we need over $1 million to do sleep studies for a validation study. That's where we're at with this. But it complements what you see on the pediatric sleep questionnaire. So that's my golden retriever. That lets me know I have about 25 more minutes. And God, I did it. No, I don't. I've got 13 minutes. So this is how you can fix jaws that are too far back. This is one approach. Okay? Sorry, I probably should have warned people. That's my daughter. Okay? I didn't know how to do this for my own kid. Okay? So this is part of my motivation. Waiting for this kid when she was under for 9 hours on a table in St. Louis. Reza Movahed, the surgeon, did this on her, was brutal. I don't want parents to go through this. Parents can hear it in my voice. And I will tell them, this is where your kid, not as a fear tactic, but if it's just, it's too early and my uncle's an orthodontist and he thinks you're a quack. And, I'm not an RO, a real orthodontist. So, and even unethical, I get called. These are my daughters. The little one, she looks like, that she had that, so she didn't need it because I had been learning how to do this type of treatment. But here's my baby. She's 28 years old now. And this is her after her surgery. This was, 10 days after surgery. So, I'm really an advocate for preventing this. But it was not fun seeing her in the PICU for 2 days on, life support, essentially. So, we did that. Sorry. We don't need to do that again. Okay.
There are no diseases associated with malocclusion at all, none.
What do I call that? Let's hear it again.
There are no diseases associated with malocclusion at all, none.
So I've done a poor job if anyone believes that. That is the biggest crock of nonsense. And this is the guy who's collaborating to put away John and Mike Mew. And this is, but he's a brilliant man. He really is. But cognitive dissonance, how could you, with all the literature that's out there, well, it's not a prospective randomized controlled trial nature. Guess what? You can't run a prospective randomized double-blinded controlled trial. You can't withhold a known therapeutic procedure for the purposes of creating a control group. How come? The Nazis. You can't do that. It's unethical. You'll never get through IRB, or you shouldn't get through IRB. All right, so you're not going to find that data, but it's a myth that people hide behind. Yeah, I got 10 minutes. What am I going to do? Okay, so this is some of the literature. How is it that this causes quality of life differences? Well, maybe, just maybe, and this is like myopia, you know, and I'm not going to have time to play that, cardiac issues. Maybe the kid's blood pressure went down when you expanded them. You know, they haven't done this, but, you know, maybe lifespan and health span. Why does that happen?
Does not mean that you must do the
That's
same.
Peter. This is the book you got to get. Take a picture of that. Very important book.
Your longevity is more malleable than you think.
So, otitis media, it clears up in a lot of kids after you expand them. You know, class 2, distal step. Sometimes we'll become a class 2. Will always become a class 2. That's a myth that it won't always do that. That's mythology, okay? And it's all over the literature from some very prominent heroes. Jim McNamara, one of my heroes, also, that taught you got to get in early. He said by age 7. Look at this, going back 100 years, myofunctional therapy, okay? Alfred Rogers talks about it. But distal occlusion, that's class 2. Muscle training. It's a big deal. Importance of factors that happen before due, prenatal factors. That's what I'm going to be talking about. So this is a study done at Harvard. They withheld treatment. This was before, right around the Nuremberg trials, but it wasn't out. And they withheld treatment to see what would happen. Nothing happened. The malocclusion stayed the same. It got more complex. Okay? And this is, again, at Harvard in a prominent peer-reviewed journal. Well, not peer-reviewed. Peer-reviewed doesn't come until after evidence-based medicine. So there's a fourth dimension to malocclusion when it's under 6, behavior guidance, behavior management. The biggest obstacle to kids being marginalized and ignored, and it's because of the curriculum, okay? I'm not gonna have a whole lot of time to go through this, but again, I told you, kids are hardwired to assimilate adult culture, imitation. They want to please the elders. Look at me, mom, look at me. If you get the mom on board, sometimes Mr. Mom, Dads, you know, they're good for support, but I am so pro-mom. I was raised by a single woman in the 60s, you know, single mom, 4 boys in the 60s. She didn't have a college education, no job, and she got us all through. We all are professionals. So, and again, it's all throughout. The kids imitate. They want to be like the elders. They're good at it. Look at that. That's supposed to be a Neanderthal depiction.
All right. Okay, then, let's see what he said. You know what Dr. Boyd told me? He told me, this is your face, right? And so you see your airway? This is what you breathe through, okay?
You get a mom on board. You think I don't own that kid now? She's managing his expectations. I don't have to do it.
This is today. See how straight that is? Is it wider or narrower? It's wider. Do you know what happens when it's wider? It's easier for you to breathe. So this is where it makes it easier for you to breathe. Do you see the difference? Isn't that awesome?
This is not a waste of time.
Mommy, tell them about
Do
the
this.
cervical spine there, how it twists and curves.
This is kind of cool too. So look at that. Those are your bones. You can kind of not see them that great there. You see your bones? That's your head tilting way back so that you can see, so that you can breathe. You had to do that because your airway is so small. But on this one, see how straight it is?
I got 6 minutes.
It's so much better for your body. It gets straight and it gets space, and that allows your airway to be open and you can breathe better. You know what happens when you can breathe better? You run faster.
You get taller.
You get taller.
Cool.
You're a little happier, right?
Mom, what do you do for a living? Are you a doctor?
I am not a doctor. I am a civil engineer, project manager.
Wow, do you get the engineering part of it?
I do.
So, sutures, soft spots on babies' heads. There's lots of them all over the craniofacial respiratory complex, okay? And we discovered this when I was a resident in Iowa. Kids that were orally intubated, preemies, they got these big notches. We could do, those pellets were malleable. The opposite happens also, okay? And we put, we'd make these little plates so it wouldn't do that. I'm going to show you an ultrasound about how a baby extracts milk from a breast. It builds the Lafort, that incisive suture. It widens the transpalatal and mid-palatal sutures. They're all over the place. And the incisive suture goes all the way up to nasion. That whole midface comes forward, okay?
Have revealed how babies breastfeed. It was previously thought that babies use a compression motion of the nipple to push milk out. But the new images show that babies extract milk by lowering their tongue to create a vacuum.
See, right there is the
The ability to
premaxilla.
produce a strong vacuum may explain why some babies are stronger.
That whole
suckers than
premaxilla
others.
is coming forward and the mid-palatal suture is expanding during nursing. It starts in utero by sucking, chewing amniotic fluid. This is Robert Lustig. We talk a lot. This is what they do for kids now. If they fail a sleep study, they put them on CPAP. I got more than 60 seconds. I have 4 minutes. You told me I got 75 minutes from when I started. So anyway, snoring, pregnancy-induced hypertension, growth retardation of the fetus. Okay, look at this. Look at what they say. Winston used to market cigarettes. They knew that it caused intrauterine growth restriction. Well, some people want small babies, right? And look at the surgeon. That's cognitive dissonance. Now it would be, but. I got the taste of Winston and I got a small baby. Who cares what the Surgeon General says? So again, I won't talk too much about this, but this is also something that is missing from prenatal counseling. There's not one way, and this is from the ADA, not one word about airway health. Prenatal counseling, women have to breathe. Oxygen is a nutrient. Okay, why does the flight attendant say put the mask on yourself first? It's the same thing in pregnancy. That's the one nutrient that the mother has priority for. If she doesn't get oxygen, everybody dies, okay? So the baby does not have priority for that. They're already in a low O2 environment. There's something called Mount Everest in utero. The O2 tension inside the uterus during pregnancy is less than what the air pressure is atop Mount Everest, not only atop, a mile above it. It's very low O2, but the baby can get along with low O2 and still develop fine, especially the cardiac tissue. But they don't have margin for error. If a woman snores, if she has apnea, we got problems, even death. So breathing is a big part of what's considered oral health now. So we look at fetuses, from hundreds, thousands of years ago. They didn't come out with retrognathic mandibles. And now we even do cephalometrics on them. So we're saying, yeah, absolutely, this starts at birth, but before birth, probably, but we need more data. I had one orthodontic resident that was all set to do this in one of the Boston ortho programs. And then the program director left and she had to graduate and do something else. But Mount Everest in utero, 2 minutes. All right, here we go. So where are we at? This is called the Barker hypothesis, okay? Katharine Hepburn was a little kid growing up in Holland during the end of World War II. The Nazis starved them out. So they came up with this theory that babies in utero during that hunger winter, they were anticipating a lifetime of famine. So when they finally got food, they would preserve it. Well, the Allies came in and threw in all kinds of flour and fat food, and after World War II, all these babies that were part of that famine, when they grew up, by the time they were 60, all of them, 100%, had what's called metabolic syndrome, type 2 diabetes, obesity, heart disease. So it's the same thing with air. If a baby's born on top of a mountain or low O2, they're smaller, okay? So that's kind of an application of that. So he said, oh no, all babies, they're born with small mandibles. It facilitates birth through it starts with ball, has an S in the middle. Not true. You don't need a crossbite. It's synonymous. Everyone says you need a crossbite. This is a good analogy. If a shoe's too narrow, the foot can't get to the end. The upper jaw this is 100-year-old literature from Germany that McNamara quotes in his textbook. okay? Class 2s will not self-correct. Also, McNamara also says, well, patient cooperation, even though we know this isn't going to get better, we don't start because the kid just doesn't get it. No kidding, the kid doesn't get it. The parent has to get it. Well, the kid, let him cross the street with the light against them. They don't get it. No, you hold their hand. I don't know. Mythology. So I am not going to be able to really get, I think
we could take it.
This is the Dunedin study I told you about. If these kids aren't sleeping and breathing well, if they have poor impulse control, they're going to have trouble with addictive behavior, criminal behavior, and they're going to look older. Their faces age if they have better self-control as young kids, if they sleep and breathe better, is my hypothesis. And that was something that was also done in the Dunedin trial. They're going to age more slowly. That's it. I'm going to stop there.